Hello, my dear viewers. Good evening. This is Dr. Sampada Kulkarni. I'm a pediatric physiotherapist. Today, I'm here to discuss about the physiotherapy assessment and management of neurodevelopmental disorders. I'll be emphasizing more on cerebral palsy and autism for today. Let's understand what is cerebral palsy. It is a group of permanent disorders which actually is non-progressive in nature. It affects the prenatal, natal, and postnatal phases of the child's life. The prevalence of cerebral palsy in the world is 1 to 4 cases of CP for every 100,000 live births. What is the classification of cerebral palsy? It is divided into 3 types, like topographical classification, physiological classification, and GMFCS classification. So the topographical classification is based on the body parts. Monoplegia, one limb is affected. Hemiplegia, one side of the body is affected. Diplegia, the lower limbs are more affected than the upper limbs. Triplegia, any one side plus one limb is affected. Quadriplegia, all the 4 limbs are affected. Next is the physiological classification. It includes spasticity, dyskinetic, ataxic, and mixed. So spastic meaning it is characterized with stiff postures of any limbs, like all 4 limbs or any one side of the limb, as I told you in the topographical classification. Dyskinetic CP means it is involuntary in nature. So it has 3 subtypes, which includes dystonia, chorea, and athetoid. Next is the ataxic cerebral palsy, which is related to the motor coordination loss and loss of smoothness in the movements. And the last type is mixed, which includes like all the above classifications. Moving on to the functional level, that is the GMFCS classification. There are 5 levels in this. Let's come from the level 5. Level 5 tells you about the limitations of the voluntary control or the impairment in the voluntary control. In this, the child is extremely dependent and is on the adaptive device. He cannot control his own device. Level 4, in that he can operate his wheelchair, maybe a motorized wheelchair or with somebody or with some certain help. Level 3 will tell you that the child is able to walk with a walker support in the area, like in the home environment or surroundings. Level 2 will tell you about the level 2 will give you an idea about the child walking or he's able to walk independently but requires assistance, like requires supervision. Level 1 will tell you that the child is able to walk independently without any supervision. Now, let's understand how to start an assessment of a child with CP. The first thing what we always want to know about the assessment part is the chief complaint. The chief complaint has to always be in the words of the parents, and it should always include global complaints and not just physical complaints. There are certain questions which we can ask or phrase while we ask the mother these things or the complaints, which is that the child is your child able to hold his or her neck? Is your child able to sit, stand, and walk independently? Does a child grasp and release object? Does a child, coo or babble or speak any word in particular? What does a child eat? Meaning, what type of consistency or what type of food that the child eats? Does he eat liquid consistency or semi-solids or solid consistency? And is your child's understanding age appropriate? And how dependent is your child? These are the chief complaints, questions which can be asked in the chief complaints. Now, the abilities of the child. Ability will, usually has to be the maximum functional independence of your child. You can identify the abilities in a way if the child is able to recognize the parent. If the child likes to listen to certain type of music, if the child is very happy if he's in certain environment, or if the child is approaching if the child is approaching towards an object from right or left, irrespective of the size, like the side, you have to mention the ability of your child, and this ability will help you in doing the rehabilitation part, because ability is important for us, for a therapist to understand. And you can also mention if the child is able to side turn or turn roll, or at least if you make him sit, he can sit for some time. All these details need to be mentioned in the abilities. Moving on to the history. History has three main parts, that is the prenatal, natal, and the postnatal history. Before that, we can ask the parent if there is any family or a genetic history in the family, and if there is any history of consanguineous marriage, meaning the marriage was in the blood relation or in the relation of the family. If the father is married to the cousin sister, or like aunt's daughter or something, this is a family chain which needs to be ruled out. Then the prenatal history, which tells from the conception of the mother to the birth of the child. So here are the questions which needs to be asked to the mother: that what was the age of the mother during the time of delivery? If the mother's age was more than 30 or 32, if she tells you that, then we can correlate that the picture, like age is important, because we can there are a lot of chromosomal abnormalities or like syndromes, example Down syndrome, which can be, yeah. So any history of previous abortion, time period between the last abortion and the patient's date of birth, any fetal movement was felt to the mother, like quickening is what we call as the fetal movement. If any fetal movement was felt, and when was it felt? Was it felt efficiently? And usually the mother should feel it around 4 to 5 months. But if it as she's not felt it, then that's a concern. Then we have to ask that question also. If the mother had any history of metabolic diseases, high blood pressure, gestational diabetes, thyroid, or infection like toxoplasmosis, rubella, cytomegalovirus, or hepatitis virus. If the mother has any history of like any medications were taken or any drugs were taken during pregnancy, if she had any trauma or stress during pregnancy, any history of smoking or drinking also needs to be mentioned. Moving on to the natal history. Natal history will tell you about the like if we need to ask the mother if the child was born full term after 9 months, completely after 9 months, or before 9 months, that is preterm. If the child was born in 7 months or 8 months or 6.5 months, this has to be mentioned, and the reason of this has to be mentioned. Mode of delivery: if the child, how was the child born? Like, was it normal, full term vaginal delivery, or was it a C-section delivery? C-section also has two types, that is the emergency C-section or the elective C-section. So this question needs to be asked to the mother: what type of delivery was it? Then type of delivery: was the child born through vacuum or through forceps delivery? Then presentation: if the child was a vertex, like if the child was born via the head, or the child was born through his buttocks or the leg first. Any history of prolonged labor, anything more than 20 hours is prolonged, that the mother goes into a prolonged labor. This question needs to be asked. And if there is prolonged labor, then there are chances of hypoxia to the child's brain. So this needs to be ruled out. Any birth injury, if the child while was born did it have any injury to the brain while handling through anybody, needs to be asked. Then the postnatal history is from 2 months till 2 years of life. The question, like, was the child's birth cry immediate or delayed? If immediate, then when? And if delayed, then when did the child cry? Like, did it even cry, or what was the intervention taken? Like, what did the doctors do if he did not cry? And what was the birth weight of the child? Birth weight determines the the nutrition value of the child. If the child has like if he has a good birth weight, he'll do a lot of his Apgar score will be better. If the child has low birth weight, then he may have to get into a neonatal ICU for intervention. Any history of distress or meningitis, pneumonia, pathological jaundice, seizures, fever, infection, sepsis, hydrocephalus, hypoglycemia. Any history of neonatal ICU stay. If the child, example, if the child mother tells you that the child was born in 7 months, then you need to ask her if he was in the ICU for how much duration, and what was the therapy, or what did the therapist, the pediatricians do in the ICU. Was he on the oxygen or the ventilator or on the nasal prongs or something? Has to be asked. Any history of trauma to the brain till 2 years of life needs to be asked. Nutritional habit of the child till 2 years of life needs to be asked, and feeding difficulties need to be asked. Then moving on to the developmental milestones, it's very important for a therapist to know what is the normal development, so that we understand what abnormal is. So these are certain developments, like this is the gross motor development. So what all happens in what all months is mentioned in the slide. Moving on to the fine motor development. Moving on to the cognitive development. Speech development. So we need to correlate if the parents tell us that he did not, babble, or he's not doing this or that. Needs to be mentioned in the history very significantly for us to rule out any diagnosis. Any social or emotional development, is there any delay in that, needs to be mentioned. Then comes the medical history. If there is any history of hospitalization of the child due to any reason till date, it could be high fever, it could be febrile seizures, it could be any pneumonia, any distress. All of this needs to be mentioned, and what all medication was he under needs to be mentioned. Then the surgical history. Surgical history is very important for the physiotherapist point of view, so that we understand if he had any history of tendon release, or if he has any history of peg insertion, or any history of hip dislocation, and if he was operated for the same, when was he operated, what was the surgery which was done, and when was it done, and where was it done, is important. Seizure history also is extremely important, because we need to understand the nature of the seizure. We need to ask the parent what type of seizure, in just in random words, how was the seizure, what was the nature of the seizure, how much duration or how much seconds did it last for, what is the frequency of the seizure, and what was the injection or what was the medication given to the child when the child got seizure, and what was the intervention, basically needs to be asked. Then present medications, from like currently what medicine is going on with the dosage and when is it given, needs to be mentioned. Investigations are extremely important for a physiotherapist. For the child, if a child is non-ambulatory, we definitely have to look onto the spine X-ray, hip PBH X-ray, chest X-ray for any deformities if the child is non-ambulatory. Also, for us to lead to a diagnosis, MRI brain is important, CT brain is important, EEG is important to rule out if the child has any active seizures or no. USG brain is also important. Then comes the examination on observation part. On observation, we need to. This is the previous slides were about what we ask the parent. Now this from this slide is about what we observe on the patient. Example of for general observation, we need to know how is the arousal level of the child. If the child's arousal is if he's very dull, low, and does not have any he's not happy, doesn't want to look around, that is one arousal. And if he how is his emotional state, if he's very extremely happy, if he's okay, like if he's crying, or if he's very irritable, he just wants to be around the mother, all this needs to be mentioned. How is his response to any kind of stimulus? Example, if you show him some video, how is he okay with it, if he's happy with it? So this will tell you how to move on with the therapy. This is how you lead toward therapy of a child. If his arousal is low, we have to improve the arousal. I'll tell you all this when we do the management slide. Then abnormal attitude of the limb is whenever you see that child, what attitude is that child's limb has to be mentioned. Built and nourishment, meaning how is the child's built, if it's ectomorph, or if it is endomorph, or if it is mesomorph. Then involuntary movements are important. The first movement that you saw here is dystonia. This child just went into dystonic movement. This is chorea. This is chorea. This is athetoid. If you see any of these involuntary movements, it needs to be mentioned. As I told you, this will lead us to a diagnosis, and observation is extremely important in our role. Second most important part of observation is the posture. Posture will tell you about what the child is recruiting, what muscles are tight. That will also help you in the exam, like the therapy point of view. In this, if you see this child, he is lying in supine position. If you see, he has his shoulder is in flexion, abduction, external rotation, elbow is flexed and supinated, wrist is in minimal extension. He has basically a frog leg appearance. his hip flexion, hip knee is flexed, abducted, and externally rotated. So all these postures need to be taken care of. Then comes in supported sitting. In supported sitting, how is he sitting? He's having slouched kyphotic spine. He has rounded shoulders. He's sitting on his sacrum, and we've given him support to sit. His shoulder is flexed, elbow is flexed. All of this needs to be mentioned in how is he able to do things when you make him do it, or however how is he doing it is to be mentioned. Then in supported standing, what is his posture like? His neck is in flexion, shoulder flexion, adduction, internal rotation, elbow is mild flexion, mid-prone position, trunk is in minimal flexion, hip knee flexion, adducted and internal rotation, ankle is in plantar flexion. Then comes the gait pattern. Gait pattern will tell you how is the child walking. If he is ambulatory, the gait pattern needs to be mentioned importantly. In this, the child, he has bilateral hip knee flexion, ankle dorsiflexion, plantar flexion. That means that he is in typical crouch gait. So this is a hemiplegic gait. The second image also is of a crouch gait. This is of a hemiplegic gait. Excessive knee hyperextended, excessive knee flexion. So this was what we observed. Now, what is the next point is on examination. Examination is how we examine the child for certain things, like how we check for his higher mental functions. If we need to see if he's conscious, if he's oriented. We cannot ask the child if he is oriented. We need to find it out through certain questions, like if he talks, if you feel that he has such cognition to answer, you can ask him some questions. And memory, intelligence, problem solving behavior. Intelligence and problem solving behavior usually can be noted if the child has a certain amount of cognition to do it. Check for head circumference. Head circumference needs to be measured. You need to rule out if the child's head circumference is normal or if he has a microcephaly or a hydrocephalus. That also needs to be mentioned. Sensory issues. Children with CP may or may not have sensory issues, but identifying them and treating them is very important. So there are two types of sensory concerns, like hypersensitive to certain stimulus and hyposensitive to certain stimulus. Hyposensitive meaning the child will seek a lot of information or a lot of input. Like the child will want to sight or visual. Hyposensitive meaning the child will want to certainly look to the light. He will just want to look, even if it is affecting his eyeball. He will just want to look. Sound auditory hyposensitive meaning the child would want to hear to certain music. He will take a phone and put the phone on his ear and just listen to it, even if it is too loud, but they'll try to seek it. Whereas hypersensitive meaning tactile hypersensitive example, meaning the child does not like any surface. The child will just walk on toes is what is tactile hypersensitive. He will not like smooth surface, textured surface. He will just walk on toe. He will not like watery surface. He'll not like muddy surface. So he overreacts to that is hypersensitive, and seeking that is hyposensitive basically. Then visual function will we have to assess this if the child is tracking a light. If the child is able to track any light, example, dark light can be red light, yellow light, or green light, which is good to the vision, fixates any object. If the child is able to, if you show him some object, or if you only be in front of him, if he's trying to fixate his eyeball to you, is what fixation is. Nystagmus, if you see this, horizontal nystagmus, vertical and torsional nystagmus needs to be observed by a therapist to the child. Strabismus, if you see, then the auditory system, check if the child's hearing is intact bilaterally. You speak to the child, you show him some music, you ask the parents if the child responds to like whatever sound or something. Auditory system also needs to be examined. Moving on to the pediatric reflexes. Pediatric reflexes are very important for a child to grow and to integrate certain reflexes If there is a problem in integration of reflexes, that means if the child is not moving on to another reflex, that means there is some CNS involvement, or if there is some CNS dysfunction in the brain. Okay, so primitive reflexes include rooting, sucking, palmar and plantar grasp, Moro's reflex, Gallen's trunk, Landau's reflex. These things need to be checked on the child. Then the spinal reflexes include the flexor withdrawal, extensor thrust, cross extension, ATNR, and the brainstem reflexes include ATNR, STNR, TLR. Midbrain reflexes include the writing reflexes. Cortical reflexes include the protective extension reflex. So integration, does the child attain it, integrate, and when does the reflex integrate is very important for a therapist to know, so that we understand if there is any pathology in the brain, and that also will lead us to a diagnosis. Moving on to the next is the reflexes. There are two types, like superficial reflex and the deep tendon reflex. Superficial reflex includes the corneal reflex, the abdominal reflex. We all need to assess this, and Babinski reflex. Then the deep tendon reflexes are, we need to check the deep tendon reflexes for biceps, triceps, supinator, knee, ankle, and jaw jerks. Grades of DTR are these: 0 to 4 plus. Moving on to the muscle tone. Muscle tone will tell you if what involvement of which muscle is involved and how much is the grade of spasticity in the child. This is a very important measure, and this and the modified Tardieu scale, these two scales are very important for a therapist to assess. So muscle tone must be checked with modified Ashworth scale. The tone is assessed when the child is completely relaxed, and it has to be examined through full range of motion. Grades of MAS are these. Then modified Tardieu scale also is a very valid and reliable scale, which is used for a child's, like how much is the tone. We need to check the tone and tightness. Then the dystonia rating scale. Voluntary control. So voluntary control is the ability to isolate the muscle activity in a selected pattern. Voluntary control also needs to be checked for a child. How much is he able to voluntarily reach on to something, or voluntarily move anything? Move his upper body, like hand. If he's able to flex his elbow, extend his shoulder. How much is it, and how much is the grade? According to the movement, we need to grade him in that way. The child may not follow your command, but you need to give him such activities where he has to utilize certain muscles, and that's how you grade them. Range of motion is also important for us to understand how much is the joint integrity, and if there is any tightness which is developing in the child, or if there is any contracture or deformity which has developed in the child. So check for range of motion for upper limb, lower limb, and trunk. Rule out tightness, contracture, and deformities. There are commonly seen tightness, like muscles are these where we can see tightness. That is pectorals, biceps, wrist and finger flexors, iliopsoas, hamstrings, adductors of hip, tendo, Achilles. These are certain deformities which can be seen. That is the hip knee flexion deformity. That is the crouch, like it looks to be crouch gait only. Abduction deformity in this. So deformity is important for us to know, firstly, because we need to look on to the hip. If there is any deformity to the hip joint or the spine, there are chances that the child may go into dislocation of the hip, which is a very sensitive thing. If we evaluate the child thoroughly, we can even prevent the child from going into dislocation by managing the tightness and managing the contractures and deformities. But for that, identification of that is very important. So in this patient, he has abduction deformity. In this patient, he has a windswept deformity. Windswept deformity is a classical feature of like initiation of hip dislocation. Then severe adduction deformity, wrist flexion deformity. This is a pronated foot. So any kind of deformities needs to be mentioned, and the intervention needs to be planned according to the deformities. Now the outcome measures. we use gross motor function measure. Gross motor function measure will tell you about how much is the like functional level of the child. If the child is able to, how much percentage is he able to sit, if he's able to crawl, knee walk, or walk on knees, or creep, or stand on knees. How much is he able to do all of that on 100 is what we measure. And here also we mentioned the GMFCS level. If in what level does he fit into? Level 1, 2, 3, 4, 5, according to the age. Then the head control and the visual gait analysis. Head control scale, if for a child who does not have head control, if the like we have to grade them accordingly. And the visual gait analysis, for children who are ambulatory, how do they walk? Like in the stance phase, in the swing phase, how are they walking needs to be mentioned. The pediatric work balance scale, it has 14 components, which and has a total score of 56. So we need to assess this on a child, demonstrate the child to do, and he has to do. There are a lot of instructions given. We have to follow that, read that, and demonstrate it on the child and get it done. And we have to grade him on 56. So this can only be done if the child has, like, if he can follow commands and has that cognition to understand. Now, let's come to the management of cerebral palsy. What is the aim for us to do this? Like, what is the aim of physiotherapy is to promote independence, to increase the level of participation at home or in the environment of a child, facilitate motor development and function, improve strength and endurance of the child, enhance learning opportunity is very important, ease challenges associated with daily caregiving are extremely important. That is what our goal is, to ease the challenges of associate and like help them get into their ideals is what we want to do. Now, treatment of a spastic CP, how to begin with the treatment. If there is spasticity, if there is a lot of tightness, we cannot directly go on to, strengthening the muscle. Stretching the muscle is very important, followed by strengthening. So if there is a wrist flexion, flexor tightness, we do a lot of wrist extensor stretching. This is basically stretching of upper limb. These are few stretches which I have taken in the slides. Wrist extensor stretching, then lateral chest wall stretching, anterior chest wall stretching, side stretches. Side stretches are usually done for children who have scoliosis, and we stretch one side and strengthen the other side. These are lower limb stretches. First images of a child. We're giving him hamstring stretch. If you see, this muscle is extremely tight. Tendo Achilles, this muscle we are stretching. Adductors of hip, this muscle we are stretching. Now, moving on to the activities, what can be given for a child to develop or achieve the neck control is kneel standing, promoting. The kneel standing can also promote neck holding. In this, we have just made a child attain a kneel standing position, and with support, we're giving her visual cues. So if she at least weight bearing on the hand, she at least tries to lift her neck up and look at the phone or the music what she likes to listen to. Bouncing on a ball will really improve. As I mentioned you in the previous slide, bouncing on the ball will really improve the child's arousal level, which will improve the neck control. That's how we are trying to do. This child had very poor arousal, and we really, like, after bouncing, she really was very happy, and she started looking up, she started looking into the environment, which was very good. 90-90 sitting, promoting neck holding. In this position, the child's lower limb needs to be completely supported, like in a 90-degree position. The upper limb needs to be supported on a table. The therapist is just promoting her to look up and push her upper limb and look up is what we are trying to promote. Tummy time, promoting neck control in quadruped position. So this child really liked music. So if we gave her a lot of musical toys or sang songs for her, she would really look up and want to listen to songs. So as a therapist, it's important for us to find out what does the child like, what does the child dislike. Then that only can be used in a therapy. Then comes supported standing, promoting neck holding. In this, I was just trying to she was not able to hold, like, push the upper limb. That's why we've given her pedi wraps. So pedi wrap will really help her push the upper limb and take weight on the lower limbs, which will in turn help her hold the neck. So neck holding can also be improved with the neck roll that we have given. If you see, a lot of children that I shown you in the videos have neck rolls. Neck rolls will also help the child to not hyperextend and hyperflex. It will, like, to a certain point, will help the child to maintain the neck in neutral position. That's what we are looking for. The child who doesn't have neck control can be given a neck roll. It is just a towel. You just have to roll it and put it around and see if the child's neck is not choking. That's the only thing we can do. Now, activities for developing trunk control is quadruped with reach outs. This is a case of right hemiparetic CP. So if you see, she was not holding, like, she did not want to take weight on the right side. That's why we gave her a pedi wrap, which will support, like, give a support on the right hand. And we're giving her a reach out. So she shifts her weight to the right side and takes weight, at least learns to take weight on the right side. Sitting balance on mat. He has just learned to sit. We are just giving him direction, unidirectional play. And if you notice, he has right upper limb spasticity or tightness. And that's why he doesn't want to use his right side. That's why we are promoting a lot of right side activities. Reaching out on a ball. This child, she has to go reach to the tissue paper that she was very attracted to. She has to take her whole body, translate or transition it towards the right side or left side, and go and reach to the tissue paper. Kneel standing while promoting neck control. This is a bolster, the pedirap neck towel roll. I'm just preventing him from hyperextension. I just expect him to take weight on his upper body, knee, and look in the front. We are giving him some visual cues which he was liking. So here also we are promoting neck control, with which we are promoting the upper body and the trunk control also at some extent. Now, prone extension activities. These are the activities which will improve slouch posture, as I told you, which will learn the child will learn to recruit the back extensors, scapular retractors, and if you see, this child is on a swing. We are just giving her some balls. She has to put it in the extend her back, look onto the object, and put it in the basket. In this, also, I'm asking her to bilaterally lift her hand up. This is a Superman pose. What I expect her to do is hold on to that, but she's just learning to. Then trunk rotations. In this, the child is expected to rotate her trunk, balance onto the swing. In this, the child is expected to rotate, take that object, and balance without falling on the swing, and give the ball. Then kneel standing activity on stable and unstable surfaces. So we are still talking about the trunk development, core trunk development. So this is a stable surface. We are expecting her to balance in kneel standing position, reach to the toy and fix it in the stack or fix it. And this is on the unstable moving surface. We expect her to hold on to that position. Then coming up to sitting. This is for the tummy muscles, that is the core muscles. So she is just learning to come up to sitting, and she's very like, she wanted this and French fries, and that's why we showed her that French fries, and that's how she got motivated and came up onto the sitting position. So sometimes to achieve something, you need to show them some reward, show them something or give them some reward. So they get motivated. Motivation is very important. And that will come through the therapist or the parent to them because they will not know what to do when. We have to give them certain directions. This guy also, we were asking him to stack the rings. So he was coming up to sitting from the ball, which will in turn develop his core, trunk, rotators, pelvic bridging, donkey kicks. All this will develop your buttock muscles, core muscles, back muscles. Sitting in 90-90 alignment will also develop your back muscles. She is learning to sit on mat with hand support. So right hand, as I told you, is affected in her. We just want her to take weight. She's just learning to sit. So weight bearing, the pediraps will really help her in weight bearing. Then comes lower abdominal strengthening. So I'm asking this child to hold on to a bar and she just has to lift both her legs together and push, like kick the ball together. That will develop her lower abdominal muscles. In this, I asked this child to, he found that clay or the theraputi very attractive. So I wanted him to lift both his upper arms together and I expected him not to fall. Like I was working on his trunk and the upper body control. And since he was in slouch and he was in flexion attitude, I was giving him a lot of extension uh, movements. Then activities for developing sit to stand. So transition by transition, the treatment will differ. So we saw about the trunk, what all can be given and achieved with the trunk. And now it's pull to stand. When once you feel that a child is ready to, sit to stand, you need to change the direction of the therapy. Pull to stand. With the help of a wall ladder, we are just expecting her to hold on to that and come up to standing position. So she was learning to take equal weight bearing, equal distribution. She was learning to do that. Pull to stand. So I was wanting him to bend forward, hold the stick, and come pull to stand to achieve. Like he wanted that ball, so that was his motivation. That's what I told him. If you want this ball, you have to get up and come to me. So another video of pull to stand is this. Then developing standing balance. So in this, we were expecting him to, like it was a 2 point stand, double point support. We were wanting him to at least stand for some time. So how will we make him stand? Because he did not want to do anything, any of these activities. So it was very difficult for us to make him, like motivate him to do so. So we gave him certain rings and we asked him to at least stand and stack those rings and then you can sit down. So, like a therapist only will understand the maximum potential of a child, and it's very important for the therapist to push that child to the maximum level potential. This guy, we were expecting him to have a single point support. He again was in crouch and in a slouch posture, in flexion attitude. So, giving him extension and reach outs in extension was really helpful for his posture to develop. Attempting to stand with calipers alone. So she's worn calipers and she stood for her by herself for the first time. So we are giving her unidirectional reach out for her balance to develop better. So she was very scared. But again, we need to try so that the child achieves the maximum potential. Then standing on a frame. Preparation for walking. So as we move on to the transition of walking, all these previous things what I was showing are very important for a child to come to walking. We cannot like the goals or whatever we decide on the rehabilitation part has to be decided on the level of the child, like the GMFCS level of the child. If the child's level is 5 and 4, we cannot expect that child to, walk so soon, or that certain interventions need to be planned accordingly. But if the child has level 3, level 2, or level 4, and maybe level 3 and 2, then we can push that child to walk. So, understanding the level of the child and, making that, transforming that child into something is very important. So, half kneeling will help you in dissociation. Half kneeling will also reduce the tightness of the adductor muscles of the hip. So in his case, he had scissor pattern. So I wanted to break that by giving him dissociation, inter and intra limb dissociation both. In this, I'm trying to give him trunk and pelvis dissociation. So I'm just trying to give him, if you see, I've held his lower limbs. One is in abduction, one is in flexion. And the upper limb, I want him to dissociate his lower and upper limb both. In this, I expect him to, with both his hands, he should touch the wall and take the ball. Working on the sustenance of any muscle will really help them for long term. Ball kicking and standing, in standing and sitting, ball kicking will help them develop better stepping, hip flexion. So if you see, he has to lift his hip and kick the ball. So these are the preparations which we do. We cannot directly get the child to walking. There are certain things which need to be taken care of. Like if he's able to stand, and if he's able like stand with support, and if he's able to weight bear, weight shift, if he's able to step, like has this amount of stepping like the way he has. We can train side ball kicking and sitting also. Then initiating step up with support. So I asked him to hold the walker. I just wanted him to step up so that we develop his standing weight shifting to the opposite side and stepping up and stepping down, hip flexion extension. Step up with reach outs. So I'm giving him step up, hold, and reach out. So he learns to sustain, like he learns to dissociate, one hip up, one hip down, takes weight, shifts weight, and then does. Now coming on to walking. Walking initially with walker support. This is a frame walker. We want her to at least hold. She again had a flexion attitude. She had crouch gait. So we will decide on the type of CP, what type of walker and what type of assistive device should be given to the child. In her case, I knew that she has the potential to at least kneel stand. She can stand alone with the calipers. That's why I gave her this, and that's why I knew that she would hold on to this position. Then walking with support. This is again a frame walker, posterior walker. Now in this case, we asked him to hold the rope, and we asked him to at least dissociate and walk, because he, as I told you, had flexion and he was not recruiting his extensors. So for him to stand, like extend his back, we had to give him something above so he could reach onto it. His posture would improve and he would learn to sustain it. Walking with one cane. I'm shifting his weight, giving him a feedback that he has to hold the walker, shifting his weight through his shoulder. Vision therapy. Vision therapy is the most vital part of like a pediatric therapy, because it will tell you about like if the child doesn't see, the child will not perceive anything or learn anything from the environment. So as I told you, tracking, fixation, all of these things while you assess the child needs to be very accurate. So we can like vision is a we all rely on our vision. So even the children do so. It's very important for them to see and do what they are doing. And if there is no vision, they are not learning anything, they're not seeking anything, or they're not seeing anything. So when if we identify that there's some vision issue, if the child is not tracking, there is delayed tracking, there is inconsistent tracking, or he does not track at all, zero, then we have to anyways give him vision therapy. So vision therapy can be given in a dark room with the bright lights, that is red, green, yellow light, and single light. There shouldn't be much more lights. See, if you see, I want him to track that red light, but he has strabismus. If you saw, they will initially they will not like it. The therapy needs to be very consistent. These are all vision therapy. All this was the treatment for spasticity. Now, moving on to the dystonic type, dyskinetic and dystonic type of cerebral palsy. There are certain positions which we have to give the child to prevent dystonia. And whatever, if you give the therapy, the dystonia needs to be prevented. Never promote dystonia. A lot of weight bearing activities are given for children with dystonia. So I'm expecting him to look up. There is a mirror besides. I wanted him to look at himself, and this is promoting the neck control. Developing the core muscles. Dystonics usually have over recruitment of the back extensors. So if we develop the anterior muscles, like the core muscles in them, then it would really help them sit. It would really help them stand. If you can see. Yeah. Then let's move on to how the child can sit in alignment. If the child, like, it's very important for the child to maintain the alignment. It's very important from a therapist point of view to understand the importance of posture and alignment, good alignment. If we train him in the good alignment, they'll learn to do certain activities in a good alignment. So if you see, I'm helping this child to sit in 90-90 position. I've given him an abduction pillow because I want his hip was in adduction. So we want his hip to be in abduction. So that's why we gave him this pillow, and he has just learned to sit in a good position. He is a case of dystonic CP. In this, also, we are expecting this child to sit against, like crossing the bolster with taking weight on the hand. There is a mirror in the front. We expect him to take care of his back and look at himself in the mirror. That is a feedback, visual feedback that we can give to the child. Sitting on a mat with hand support. So if you see there is a therapist who is trying to interact with him, I'm preventing his extension. That is the further dystonia that he is trying to go into. This is again a pedirap, a tal roll. And there is a music that the father is playing around so that he likes to, look up. The more you communicate with the child, the more you show certain things that they like, they'll respond to you better. Now, there are strategies which can be helpful to prevent dystonia on a stable surface. Okay. On a stable surface, he's sitting on a wedge, so his spine is above his hip, and he's taking weight of his on a table. It's the weight is distributed equally, so he is trying to look up. Now, sitting, like we are helping the child to sit on a on an unstable surface. So I expect him to hold to the swing again and look up. Over here also. He's taking weight on his hands with the help of the towel roll. We are expecting him to look up. And the swing activities will really help, to improve the arousal level of the child also. If you see again, his neck is in neutral. He's not flexing. Certain things like swing, music, all of these the children like. So we can use that as in therapies. Then sitting on an unstable surface, I'm giving him to sit on a balance board. He is balancing on himself. We expect him to look up. The song that we are playing from behind is the motivation for him. Then weight bearing activities, that is quadruped position. Then the kneel standing position. Again. Then coming on to the dissociation activities, as I told you, dissociation is very important for the child's hip to separate. Like there shouldn't be, if the child has severe adduction, severe deformity, severe tightness, then dissociation will help them. Moving on to the other one. So we were asking him to look up. Again, the mirror is what the feedback is. Moving on to sit to stand position. Sit to stand position, we are expecting him to hold to the walker. We want him to take equal weight shift. And with the help of the weight shift, like if you see, this is the shoes that we are giving. We want him to come ahead, hold the walker and try to come up. This also will be without dystonia, that we have to prevent dystonia. In this, he has stiffened his back. If you see, he has gone into dystonia, so we need to relax him. He is going in, dystonia is going behind. So it's very important for us to relax them. Then standing without going into dystonia is this. See, so alignment has to be taken care of. Posture needs to be taken care of. And the motive is for him to weight bear, to look up, look at what, like whatever is around in the surrounding. So we were working on his neck control, weight bearing, and arousal level as well. And mirror again is a feedback. This is to see how much voluntarily he is able to do activities. So there is a bubble that we are asking him to pop the bubble. If you see, he did it. Then handling a child with dystonia. So handling is very important because even if you do any therapy for 1 hour or 2 hour with like in the therapy center or something, what the parents do at home is very important because 1 hour or 2 hour of therapy will not help because the child spends the maximum time with the parents. So we have to counsel the parents about importance of handling of a dystonic child. This is what I'm trying to do. If you see, she is a case of dystonic CP and with hip knee flexion, I'm just holding her. I'm preventing her dystonia by my chest and I'm just flexing a hip and knee. This is a very good position to prevent dystonia. This is a swing which will prevent dystonia. This is a lycra swing. In this, we can give him that comfort, that cushion, what the child needs. This again is a position where you can flex him in this, and that would reduce the dystonia. So I have covered the assessment part. I have covered the management part of cerebral palsy. If yeah, I am open to any question if you have any questions. Okay, so moving on to the next topic of today's presentation, that is physical assessment of children with autism. So I'll be covering the assessment of autism and also the management of autism. So, it's there are a lot of parents who tell us that the child with autism, my child is okay, he does not have any physical issue, he runs, he jumps, he does everything. But it is a role of a therapist to identify if there is any concern or a physical query and to convey this to the parent and tell them the importance of what the physical issues are. So let me tell you and emphasize you on the physical issues. Again, this will like we have to basically ask them questions. Like previously, as I mentioned in the CP assessment, whatever questions I asked you, we asked for CP children if the prenatal natal history is significant, if the developmental milestones were age appropriate, if there was any seizure history. All of these questions will remain the same. On observation will change. So I'll emphasize on the observation part now. Coming on to the posture. Now, in sitting, the children, the parents, when we ask them, how does the child sit? They'll tell he sits like this, he takes his or her leg behind and sits. So, the importance, the parents may not know the problem with W sitting. We need to explain them what happens with W sitting. This is a W sitting position, and if the child has excessive W sitting, this is how the alignment of the child will become. The hip and knee are if you see it is adducted, internally rotated, and pronated. So the child walks like this is because of severe W sitting. So we have to explain these points to the parents. Second is the winging of scapula. If you see winging of scapula, increase in the lumbar lordosis. All these are the observations which we need to observe in a child with autism. Then genu recurvatum, excessive knee hyperextension with excessive lumbar lordosis. Genu varum, genu valgum, flat feet, pronated feet, toe walking, tippy toe, toe standing, toe walking, tippy toe. Like all these can be the terminologies. In towing also happens because of W sitting. Excessive W sitting can lead to in towing. It can lead to adductor tightness, adductor of hip muscle, hip tightness. It can lead to like deformities. It can lead to spinal involvements later on if the child persistently sits in W sitting. The gait gets affected. And there are chances of the child having hip dislocation also if there is excessive W sitting. Slouched posture. Gait pattern will include wide base of support, in towing, or toe walking. Then on examination, again, you need to assess for the child's tone, child has any tightness, how is the muscle strength of the child, fine motor, if there is any fine motor involvement, impairment, like grasping, releasing, prehension, precision, opposition, all of these. And for motor skills, you need to, in general, check if the child is able to walk, run, jump, hop, ascend, descend the stairs independently. Yeah. If the child is able to walk, run, jump, hop, ascend and descend the stairs independently, catch and throw a ball, skip, kick ball, or heel walking and squatting. These are the motor skills which will tell you how is the balance and the coordination of that child. Then like there is a lot of query or debate on like if the sensory issues could really lead to physical concerns in a child. As I mentioned to you in my previous slides, hypersensitive and hyposensitive. I'll emphasize on the proprioception now. Proprioception tells you the awareness of body position and movement in space. So if an autistic child has any proprioceptive function dysfunction, then it refers to the component. Like, what is proprioception? It refers to components of muscles, joints, tendons that provide a person with subconscious awareness of the body. If the child has any proprioceptive deficit, then the child will not understand where his body, where does he lie in the space, where is his body in the space, what is the awareness. He will not have any sort of awareness. And the proprioceptive system is responsible for providing the body with signals that allow us to sit properly in a chair, sit erect on a chair, step up over something, step down over something. So you will see a lot of parents complaining you about my child is very clumsy. He does not want to, stair climb. He is very scared of stair climbing, getting down. He is very scared of getting up from the floor. All these insecurities or all these gravitational concerns or proprioceptive dysfunctions. So it is a role of a physiotherapist to identify such dysfunctions and explain or counsel or educate the parents about the importance of this and then move on to the diagnosis and therapy. So clumsiness is what some parents will tell you. Tendency of fall. My child falls, keeps on falling. Lack of awareness. He bumps onto something. He does not know if there's a door, there's a wall. He just goes. Odd body posturing, minimal crawling when he was young. A difficulty in manipulating small objects, buttons or something. Eating in a sloppy manner. Resistance to any new motor skills. So what are the we use like certain skills, one of which is test of gross motor development to rule any query or any concern with the locomotor skill or object control skill. So test of gross motor development is TGMD, what we do over here. Locomotor skill will tell you about the running, galloping, hopping, leaping, horizontal jump, skip, slide, etc. Whereas the object control skill will tell you two hand strike, bouncing, stationary bouncing, kicking, catching a ball, kicking a ball, overhand throw, upper hand throw. So this is how we can grade a child. This is a scale which can be which can tell us about how much is the child's potential to do certain things. This is only applicable if the child is good in cognition and if the child has the ability to follow commands. Now, for the management, like if I, as I told you, for W sitting, if the child has excessive W sitting and the parents tell he just sits in that position, there is something known as a pedirap, which we were using for the upper limb in the cerebral palsy children. There is something which can be used for the lower limb also. So it will not let the child bend his knee. It will just keep the child's legs straight, and he will, maybe initially he may resist to wear it because they are so habituated to W sitting that they do not like to change the positions. But it is very important for the parent and the therapist to see, identify that, and give him proper advice, like the pediraps. A lot of side walking activities, because excessive W sitting will lead to adductor tightness of the hip muscle, hip joint. And that's how we give him butterfly stretching, side walking. Side walking is given because adductors of the hip are tight, so the abductors of the hip are weak. So we stretch one component and strengthen the other component. So activities for slouch posture, prone extension on the ball, crab position, supine to sit on a ball, reach outs on a ball unidirectionally, activities for genu recurvatum is squatting, squat to stand on a moving surface, wall squats. For flat feet and toe walking are extremely like commonly seen conditions in children with autism. So toe walk, the flat feet will sorry, the flat feet is always in two types. That is the flexible flat feet and the rigid flat feet. If the normal arches of foot in the children develop till the 6 years of life. But if the flat feet still persists after 6 years, then we have to explain to the parent that your child has flat feet, and it may hamper later on he may or may not have hip, knee pain or ankle pain, but it is a significant concern. Secondly, W sitting also will lead to flat feet or pronated feet. So finding the root cause also is very important. These are certain activities which will try to develop the arch. That is this. Giving them textured training, giving them balance training. This is a balance disc. Then over here we give insoles or arch support for children who have flat feet. So this is an arch support which has to be worn in a closed shoe, and it is very important for the parents to understand the importance of an arch insole, because they usually wear it in a open shoe or in Crocs or something. But the arch, this wedge needs to be below the arches, exactly below the arches, otherwise there is no use of it. And advise them to keep it worn for at least 4 to 5 hours in a day whenever the child weight bears or runs or does any physical activity, especially. Then moving on to the pronated foot. Flat feet later on gets into the pronation of foot. Pronated feet is basically a navicular drop. So this also can be caused because of W sitting or proprioceptive dysfunction or low muscle tone, and lack of activities can also lead to this. So this is a SMO, that is a supramalleolar orthosis. Sorry, this is a supramalleolar orthosis which prevents, like, it will not, what do you call? It will not reduce the pronation, but it will prevent it from further deformation. And if the child at age of 8 or 9 has a pronated foot, it is better that we advise them the SMO, because later on, if he persistently walks in pronation of foot, it would lead to hip and knee alignment issues also. So it's better that we counsel the parent to get a SMO done. The second most important thing is toe walking. So toe walking has like it is a query that, like, there are a lot of parents who tell us that toe walking can be because of sensory issues, which is very definitely it is because of the sensory issues. But when the sensory issues persist for a longer period of time, it goes on to the musculoskeletal issues. So sensory issues meaning it is because of the tactile hypersensitivity that the child has. That is a pure sensory concern. But because the child has that sensory issue, he continuously walks on toes, which leads to a musculoskeletal issue, which leads to tightness of the tender Achilles muscle. So initially, if we need to rule out if it is a sensory issue or a musculoskeletal issue. For ruling it out, we need to check if the child has developed any tightness. If it is mild, moderate, or severe, we need to check that. We need to check if the child is able to walk on a like textured surface, like if he's able to walk on a sensory mat. This sensory mat includes a doormat or like a rough surface, like any different type of texture. If you make him walk, you need to see if he's walking on his heels. But if he does not, and if you on the examination, if you see that there is tightness for him, then you have to check for the muscle tightness, how much is the tightness, and give him stretching. Like in the intervention, you give him the stretching part. Then give him a lot of stepping up, stepping down activities on the heel. Usually because of the toe walking, the center of mass falls anterior to the base of support, and that's why the child does not want to flex forward. The trunk flexion is very, like, they do not want to do trunk flexion, they do not want to do knee or hip flexion. So that is why core muscles also start getting weaker. They develop lumbar lordosis, excessive lumbar lordosis. Core muscles get weaker, they do not bend or knee flex. So a lot of crawling activities will be advised for developing the core muscles. Then a lot of knee flexion activities. He's standing on a peanut ball. I'm expecting him to, squat down with some support and stack the ring in the set. I'm giving this child to step up and step down. Now, even if you do all of this and if you examine that the child has moderate to severe a tightness in the in the TA muscle, then it is advised to give high boots, which will reduce toe walking. So tightness of tendo, it is the indications are the tightness of tendo Achilles muscle, and if the TA is not stretchable up to neutral, and if the child walks on toes on any and every texture and surface. Moving on to the balance and coordination activities. So he's standing on a balanced disc, and we are expecting him to balance his own body while he plays catch and throw. So this will develop a lot of balancing, coordination, attention, concentration in the child with autism. Walking on a narrow beam, he has to look down. He should not fall either sides. He just has to stand, walk on that path, and fix the ring set. Single limb stance, climbing up on a wall ladder, balancing on a board and stacking the rings, balancing on a T hammock while stacking the rings. Now, coming on to the motor planning activities. Motor planning activities are such activities where the child has to do a lot of, we give them a lot of approaches. They have to identify what they have to do with that activity. So in this child, we were asking him to cross the ladder, walk on a wedge, walk on a balance board, balance himself on the disc, and then finish the activity. With this child, we were expecting him to step up, get into the tunnel, come out, take some reach activity, and come out and fix it back. So motor planning also is very important for children with autism. We expected this child to walk on a bolster without falling, whereas he has to concentrate, he has to balance his own body, he has to walk while he looks down as the bolster moves. So he shouldn't fall. With this child, the child has to hold on to the trapeze, and the child has to we will ask him to hold the trapeze and lift the legs up so he can hang and swing. So hanging also is a very important activity to improve the back, the strength, stretch the back muscles, improve the lower abdominal strength. This is in this position we are trying to strengthen the buttock muscle by giving him donkey kicks. Basically, these are donkey kicks. So I have covered my activities, like I have covered the rehabilitation part in autism. Moreover, even if the child may have or may not have any physical activities, it is important for a child with autism, ASD, ADHD to get into certain physical activities, example, aquatic therapy, example, swimming, example, any outdoor activities like cycling or any sport like soccer, basketball, cricket, which will improve their strength, which will reduce the hyperactivity that they have. Basically, the energy expenditure will be more, and we have to, like, they are very hyper, and that's why we have to give them some sort of calming down activities. With a lot of physical exertion, they will, in the end, calm down, and that's what is the aim. So, all these activities and therapies are very important. I'm open to any questions if anybody has anything. So as I see, there are no much questions asked. Okay. Okay, we have a attendee. Okay. Thank you, everybody. So if we have any questions, okay, we have a question. How do you deal with a child with gravitational insecurity? So gravitational, firstly, though, we need to identify what is the gravitational insecurity. If he has any difficulty in sitting on a swing, if a moving swing, any moving surface, if he has any difficulty on walking on uneven surfaces. So the more you give him exposure to certain activity, such activities, the better he will develop. The more consistently you do, better he'll develop. Okay. Any other questions? What is a key feature to help in knowing a child has autism? So the key feature meaning, so how is he socially, social interaction, and eye contact, and if he has echolalia, if he repeats his words, if he is very hyper, he does not sit into one place, is like can be termed as autism. Any other question? How do you train a child using a KFO with scissor gate? So knee ankle foot orthosis with a scissor gate. Okay. So basically, if a child has scissor gait, firstly the KAFO is used to do stretching or to do weight bearing or standing. We cannot expect the child to walk with a KAFO. So firstly, if he has a scissor gait, that means his hip adductors, internal rotation, rotators, hip flexors may be tight. But if with a KFO, I do not expect, like, I cannot tell you to treat a child, making him walk with a KFO. You can definitely stretch the muscle. You can, with the KFO, you can give him a lot of abductor stretch. You can give a lot of hamstring stretch. And after that, once you feel that you've stretched him enough, you can give him a lot of sit to stand. You can give him a lot of side ball kicking, stepping up, stepping down, a lot of side walking. That's how we will develop his abductor, hip abductor strength, which will in turn reduce the scissor gait. Any other questions? In hypotonic cases, some children will have back throwing when sitting position. In hypotonic children, we do not expect any child to have a back throwing. Usually, it is seen in dystonics. So, a dystonic child may have back throwing, and hypotonic will be very low in muscle tone. Like they may not even be able to extend the neck. So, maybe you're asking about the hypertonic or a dystonic child. Then I'll answer the question that the hypertonic child, the dystonic child, if he has back throwing, we, as I told you, I gave you a lot of handling techniques, and I told you a lot of about how to give him a lot of weight bearing, a lot of sitting in 90-90 position, giving him equal weight bearing. It's a process, it will take time, but if with dealt properly, if you give him a lot of positioning, a lot of weight bearing, lot of like not a term, like you can give him a lot of hammock swing, which will reduce the back throwing. Any other questions? How do you train a child walking with a flexed knee? So, if both the knees are flexed, firstly evaluate why is it flexed. If the knees are flexed, mostly the hamstring muscle is tight and the quadricep muscle is weak. So we need to stretch the tight muscles and strengthen the weak muscles. Firstly, stretch the hamstring muscles and strengthen, like give a lot of squat to stand activity, stepping up, stepping down activity, sit to stand activity, and a lot of quadriceps strengthening should be given to the child. Next question is, what is the best advice to mother of CP child who presents with difficulty feeding and present with malnutrition? It's a very good question. So if a child, if you're like, if I, the question, like I want to ask you a question again. If you have a difficulty in feeding, like swallowing is difficult, or the position is difficult? What is difficult? Emmanuel is the person who has asked the question. How can we get the notes? You will get this notes. It is available online. I mean, this is a Zoom meeting, so this is going to get recorded. The feeding is difficult, Emmanuel's mother. So the feeding is difficult. So mother, if the feeding is difficult, we need to find out what if the child has any swallowing difficulty, feeding difficulty. Firstly, do not make the child feed when he is in supine or sleeping position. The feeding always should be in 90-90 sitting position. There's a CP chair which can be made or which is customized. You can search it online, or if you can search our website, like you can search it in the videos also, you'll get. In that position only the child needs to be fed. Firstly, identify what type of food is the child taking inside. If it is a semi-solid, or is it a liquid, or if it is a solid food intake, and give him in small bouts and do not give him together. If the child, give him some time for himself to identify the texture and take it inside. Then only, and do not feed the child when he's in sleeping position. Any other question? It will be fantastic if there's a YouTube channel for this. Okay. We will get into this. And what are the tests done for neurology and what are you trying to determine? Chrissy has asked me these questions. I would want to know what type of what type of tests are you, in what term are you asking if you are online? Okay, Glady has asked me, I know you haven't tackled this, but is there a way to help children with autism with potty training? And 5-year-old, he's 5-year-old and not yet potty trained. Okay. This question actually I would like to direct it to an occupational therapist because they are the ones who can answer you this question better. So Glady, I can if you give me your contact number on this site, we can get back to you with the answer while talking to the occupational therapist. Any other questions? Okay. Do we have any other questions? Okay, then thank you everybody. Thank you all the participants for listening. And all the queries, if you have any, can be directed on this side. We will get back to you. Thank you.